going to talk about the bad ones. So why early intervention for ischemic priapism? Well, I think everybody knows, whenever blood goes in and blood doesn't come out, that leads to a bad situation. And we know the longer that goes on, the more bad the situation gets. So at 8 hours, we start to see some microscopic changes. 12 hours, we're getting edema. 24 hours, we're getting that endothelial destruction. And at 48 hours, now we've got necrosis, smooth muscle problems, all those things. So again, I had to quote my mentor Ryan here in his own words as someone who was on this guidelines panel that again, over 36 hours, the chance of erectile recovery really, really low. So early intervention warranted, but we all see it. We all see the patients that come in, they've been up for 24 hours, 36 hours, maybe even further, or we've tried to take them down and they just won't stay down. So what do we do with them? So again, these are people, we're talking about repeating imaging, getting things like Doppler ultrasound. So again, for everyone in the room, we know that on the Doppler, we're gonna see absent or very little flow. When we do see it, it tends to be really diminished in terms of its velocities. The resistive index, which looks at sort of the initial, systolic velocity minus the end diastolic velocity over the, the peak systolic velocities, they tend to be increased because you tend to see these big waveforms in it, although they're small amplitude. If you get an MRI, so this was the MRI actually for that guy, you see these big changes within the corpora, especially when they've been up for a while. You can see evidence of necrosis, changes in the tissue, things start to look woody. And when you examine these people, things just don't seem right. So today we're going to talk about 3 basic options to try to manage these guys. Assuming that you've tried the, the aspirations, maybe the irrigations, the phenylephrine, and it didn't work. So we're going to talk about distal shunting, we're going to talk about tunneling, and then we're going to talk a little about early prosthesis placement. I've notably left proximal, shunts off this just because, again, the idea was to talk mostly about effective strategies, and we know in most people's hands those don't work so well.